Dear colleagues, as we unfortunately had to cancel this year's World Congress in Montreal, we thought it would be a good idea to at least share some highlights from the virtual Congress that took place in February. Before the video starts, I would like to announce that the 2022 World Congress in Taipei, Taiwan will take place from June 9th to the 12th. I look forward to seeing you there in person, and now please enjoy the video. Oh, and don't forget to subscribe to our YouTube channel below for free so you can watch more videos in the next weeks. Thank you.
So my presentation today is about the prenatal steroid hormones and autistic traits and autism, and I will present a series of findings from our group in the University of Cambridge at the Autism Research Center. But first things first, so what is autism? Autism is a neuropsychiatric condition or a developmental condition, and it is defined by a series of difficulties in social interaction and communication, as well as restricted interests and repetitive behaviors. And you can see here one of the very first quotes describing autism by a leading pediatrician at the time, who, when he was describing a child age 5, he said that the child was happiest when he was alone, drawing into a shell and living within himself, oblivious to everything around him. So as awareness of autism is increasing around the world, so is the prevalence around the world. So it is now estimated to be between 10 and 20 births out of 1,000 per year. But we shouldn't really think of autism as a merely psychological condition, but rather as a neurodevelopmental syndrome that also includes a series of comorbidities like epilepsy, intellectual disability, ADHD, and gastrointestinal complications, which are actually quite common in the condition. So as the awareness of autism has increased, so has our understanding of the condition. And one of the main things driving this is what we call the sex ratio. So now that we know that autism presents a bit differently in boys and girls, we are now confident that even though we take that into account, autism remains a condition that is much more common in males rather than females. So a research group in Cambridge is trying to establish why that is. And that observation remains true in cases with intellectual disability or cases without intellectual disability. And we think, is also evident in personality traits. So this is from a big data study that was released recently in over 500,000 participants in the UK, where we showed that personality traits in autism are shifted towards male values, so male patterns. So autistic females actually think and behave a bit more like typical males, if that makes sense. But we think that's quite important in understanding the condition and the factors that drive it. So in 2019, we revisited the same samples, and we also looked at steroids, estrogens, and we examined each hormone separately. And indeed, we found that estrogens actually were much more predictive of autism likelihood in those babies than the androgens and cortisol. And that was a somewhat surprising finding, because we always think of estrogens as a sort of female hormone, but obviously in pregnancy, estrogens in many mammals actually masculinize the brain. In humans, it's unclear how they contribute to sex differentiation, but they certainly fall under the category of sex steroids. And you can see here the levels and how they were higher in autistic males compared to controls. So this is actually not in the published study. This is an analysis I did because I thought of how androgens are aromatized into estrogens. And I wanted to see whether that process of aromatization was different in autistic cases compared to controls. So we have two androgens here that aromatized in the placenta. That's testosterone and androstenedione. and they are aromatized to estradiol and estrone, respectively. So I didn't find a significant difference between cases and controls, but I would say that it's borderline. Maybe it signifies a trend. You can see the p-values here at 0.076 and 0.093, although that's not conclusive in any case. And we included those estrogens in the multivariate analysis along with the other hormones. Again, these are the same samples, and we found that, as we reported before, both a factor driving the variance in estrogens and a factor driving the variance in other steroids like cortisol and androgens, both of those factors were higher in autistic cases compared to controls. But those factors seem to be somewhat independent. So this is a second study. This time it's prospective, it's longitudinal, that we just finished, completed in Cambridge. And in this study, we recruited 200 pregnant women throughout pregnancy and then followed up their children till they were 30 months old. And we looked at the very early infant autistic traits, the sort of early signs that actually contribute to boys being diagnosed faster than girls. And we also looked at the autistic traits of the mother. And this is one of the very first studies to look at both the mother and the child in the same study and hormones in the mother. So we looked at maternal serum at around 12 weeks. So in the first ultrasound appointment, quite early in pregnancy. And we looked at the levels of several hormones, steroid hormones like testosterone, estradiol, DHEAS, progesterone, and some placental hormones, HCG, human choriogonadotropin, and the pregnancy-associated peptides, PAPPA. And then we also looked at the sexual hormone binding globulin that shows us we can use to calculate how much of testosterone is bioactive or free, and estradiol. So this binding globulin binds testosterone and estradiol, and we wanted to see how much of that fraction is bioactive. So this is a work in progress, and the point that I'm trying to conclude here with is that, okay, these hormone levels certainly tell us something, and so do the conditions like polycystic ovary syndrome and hirsutism, and they seem to be affecting males more than females, which is what we would expect, because male babies have higher levels of steroids during gestation as well. But we need to think of all the interacting systems during pregnancy, and that includes the placenta. And then we also need to think of the developing brain. So on the right here, you can see a brain organoid that some of our collaborators here in Cambridge are developing. So they're taking stem cells and they develop little developing brain organoids out of them. And then they put steroid hormones on them and see what happens. And they have very exciting findings showing that actually steroid hormones like estrogens and like testosterone play a very big part in the developing brain in both males and females. So we need to understand why males are affected by them a bit more so they develop autism. And with that, I'd like to thank you everyone for your attention. Thanks for having me.
Good evening. My name is Mark Weiser. I'd like to thank the organizers of the meeting for accepting this symposium for presentation. I think it's very important for people to have an understanding of what estradiol and estrogen have to do with schizophrenia. My collaborators are on the screen: Dr. Davis, Dr. Biegon, Michael Davidson. And it's important for me to mention here that I'm not an estrogen enthusiast. My career is not based on estrogen. I've done many clinical trials in schizophrenia. I've published many negative findings. But to start with estrogen and the brain, estrogen is involved in many different functions of the brain. has to do with inflammation, has to do with mood and cognition, learning, memory, and it's a very major and important part of brain activity. We don't completely understand what estrogen does. It activates the dopamine system, it affects serotonin, and there are certainly genetic factors involved. All of these, of course, are relevant for schizophrenia. So we took women with schizophrenia, schizoaffective disorder, not menopausal, up to 45 years of age, receiving an antipsychotic with a PANSS score above 60. So these are women who are on medication and do have significant symptoms. This study was funded by the Stanley Medical Research Institute, which is a non-for-profit organization based in Washington, D.C., which funds studies on schizophrenia and bipolar disorder. This is a randomized, placebo-controlled, double-blind, controlled add-on study with 200 women. There were 200 microgram of estradiol patches added on and changed twice weekly. It's an 8-week study, and it was performed in the Republic of Moldova. Here's the consort diagram of women. We had 95 and 94, about 100 patients allocated to each group, and the vast majority finished. We had very few dropouts. Important to show that the baseline PANSS score of our study was 82. 82 is reasonably high. These are quite symptomatic women. The Kulkarni study had somewhat less ill women with their mean total PANSS score of 73, and it worked. We met our primary outcome measure. Okay, estradiol patches were better than placebo patches in improving the symptoms of schizophrenia. Okay, this is not a mean feat. There are many studies which come out in schizophrenia which are very nice, but which are not later replicated. And we had improvements in negative symptoms, positive symptoms, and in general psychopathology. There was improvement in CGI and in the depression score as well in the MADRS. The side effects of estrogen, leading to the possibility that maybe there was functional unblinding, that actually the patient and or the doctor, because of the side effects, actually knew what the patient was getting, even though it's a double-blind study. So we analyzed the data to see, both did a moderation analysis and did not find an effect of breast discomfort or weight gain. And then we redid the analysis, just removing all the women who had these side effects, and the results remained significant. So we do think that these results are significant and are not just the result of functional unblinding. We then took our data together with Dr. Kulkarni's previous studies on estrogen patches in schizophrenia and did a meta-analysis and found a very nice improvement of about half an effect size in schizophrenia. This is quite a nice effect. Getting a half effect size improvement in schizophrenia is no mean feat. Okay, so what are the clinical implications of this? We've shown efficacy in studies done in different continents by different investigators with minimal side effects. However, the problem is that there's no patent on estrogen, there's no drug company, and there will be no marketing of estrogen. It is not indicated for schizophrenia, and no drug company can get a patent to test estrogen schizophrenia and make money out of this. So this is very problematic, and this brings us to a larger field of how to administer and how to develop drugs which are not patentable, which you cannot make money out of, and distribute them. And that's probably for the next talk, and not for the talk here, because I wanted to talk to you about estrogen and schizophrenia. So thanks very much for your attention.